Thank you. Good morning, teachers. Good morning, colleagues. We thanks Dr. Samia for giving us the chance to stand here to present a topic in International Day of Radiology. I will talk about ultrasound in ocular emergencies in the next 20 minutes. As you know, we have three types of scan that concern in ocular purposes. We have the A scan, that's the amplitude scan, the B scan, the brightness scan, and ultrasound by microscopy, which is a technique used for visualization of anterior segment using high frequency ultrasound, maybe 35 to 100 megahertz. But the B scan is the one that's routinely used by radiologists. To bring a little bit history in the picture, A-scan first used in ocular diagnosis in 1956 by Moll and Hughes. Bohm and Greenwood in late 1950s developed early B-scan, and ultrasound by microscopy developed in early 19th by Foster and Pavlin. For short overview, about 3 to 5% of all emergencies that present in emergency room are ocular. They can be traumatic, they can be non-traumatic, and it's found that more than 2/3 can be screen diagnosed using ultrasound in emergency room. Why B-scan is important in ocular emergencies? It has very low cost, its mobility, ease of use, availability, because everywhere you're not going to have cross-sectional imaging, it's real time. It has very short scanning time, repeatability, you can scan many times, can follow up your patients. And since it's non-invasive and hazardless, as there is no ionizing radiation concerned, and it's highly sensitive and specific. B-scan is indicated when there is sudden decrease or loss of vision. It's also indicated when there is ocular pain, trauma, and is suspected foreign bodies and head trauma. Contraindication, there are only few contraindications for B-scan. When there is obvious globe fracture, when there is significant periorbital injuries, and enlarged retrobulbar hematoma. About the pathologies that we concern in ocular emergencies, globe fracture, retrobulbar hematoma, intraocular foreign body, dislocated subluxated lens, retinal detachment, vitreous detachment, vitreous hemorrhage, and increased intracranial pressure. How to perform this kind of we are usually examined while the patient is supine position. Use high resolution linear array transducer 7.5 to 10 megahertz. We are using while the patient closing his eyelids, although there are centers using B-scan in open eyes. We use the large copious gel, gentle pressure, and usually we scan both eyes. We start from normal eyes to give good comparison for the abnormal. And the eye examined in two views, in transverse and sagittal. In transverse, usually we start from upper to lower, and in sagittal from temporal to nasal. And also dynamic examination, while the patient closed the eyelids. Before closing eyelids, we advise the patient to gaze forward after closing and doing ultrasound. Okay. And we do a B-scan in dynamic examination. We ask the patient to look forward, downward, right, left, while closing eyes. About the normal ultrasound anatomy, we have this is the eyelid. This is the linear echogenic line is the cornea parallel to the eyelid, and posteriorly here the anterior chamber, which is a space located posterior to the cornea, and anterior to the anterior capsule of the lens. And here is the iris and ciliary body. Posteriorly here the lens, which is normally should be anechoic. And here is only about the lens. We see the lens capsule, And posteriorly, here is the vitreous chamber, which is appear anechoic in adult healthy, and in elderly you may see some echogenic dots inside the vitreous. And posterior lining of the eye globe here is three lines: the retina, sclera, and choroid, or retina, choroid, sclera. But this cannot be differentiated in normal ultrasound. And in the retrobulbar, we see the optic nerve, which appear as hypoechoic radiating from the globe, and here the retrobulbar fascia. We will take some pathologies of the eyes. Start by lens dislocation. There are many causes of lens dislocation. We have most common cause is the trauma, and it's occur also when there is history of surgery for cataract in primary ocular disorders like aniridia, and in systemic and syndromic disorders like Marfan syndrome and homocystinuria, and in some infections like encephalitis. We have two types of lens dislocation. We have partial dislocation, or sometimes called subluxation, and we have complete dislocation. In partial, this is normal lens. In partial lens dislocation or subluxation, the lens remain attached to the ciliary body here. And in complete, the lens will be sink in the vitreous and lies anterior to the retina. And when doing dynamic, the lens will be movable with moving the eyes. Another topic is the vitreous hemorrhage. It refers to bleeding into the vitreous chamber, usually from blockage or damage to the vessels of the retina. Two major causes of vitreous hemorrhage: we have trauma and diabetes mellitus. And the most common clinical presentation is sudden painless visual loss to varying degree of severity. In traumatic cases, there may be orbital pain. Vitreous hemorrhage, it depends, the sonographic appearance depends on the age and severity. In early phase, that's early few days, it will appear as low amplitude echoes or low level echoes. This will follow up for 2 to 4 weeks. It usually resolve and clearance will occur. But if this hemorrhage become mature and organized, the membrane will form, and this is fibrinous vitreous membrane. This caused many times retinal detachment by pulling the retina. Another pathology, posterior vitreous detachment. Posterior vitreous detachment is separation of the vitreous membrane from the retina. The main cause is the age. When elderly, when aging the vitreous, it becomes less jelly. Normally, it is jelly, and take the configuration or responsible for the configuration of the eyeball. When elderly, it becomes less jelly, more watery, so unable to keep the usual shape. As a result, it becomes to run away from the retina to the center of the eye. It also occurs in trauma. In vitreous detachment, it usually occurs posteriorly because anteriorly it is firmly attached to the retina. How it appears, like in this diagram, it appears as undulating, and when doing dynamic, it moves with moving the eyes as undulating membrane anterior to the optic disc and not contact with the optic disc to be differentiated from retinal detachment. About retinal detachment, it refers to separation of the inner sensory layer of the retina from the outer pigment layer. As we said, we have the posterior, we have three layers: the retina, choroid, and sclera. The retina, when detached from its outer layer, the pigment layer, retinal detachment occur. It could be total, partial, focal, depend on extension. The warning signs of retinal detachments include sudden appearance of floaters and flashes and reduced vision. And the causes, sagging vitreous or vitreous when become shrink by hematoma or by elderly, it will pull the retina and also occur in injuries and in advanced diabetes. On ultrasound, this is a classical shape of retinal detachment. It's firmly adhered to anteriorly to what's called ora serrata, so it's not separated usually beyond this point, and posteriorly it is attached to the optic disc, so appear as a V-shaped configuration. When acute, it is thin and moving when when in dynamic examination, but when it become chronic, it becomes thick and non-movable. Retinal detachment is sometimes associated with subretinal hemorrhage which is due to trauma, age-related submacular hemorrhage, hypertension, and retinal artery microaneurysm. On ultrasound, it reveals elevated retina with moderately reflected subretinal opacities. That's the blood. Another topic, choroidal detachment. Choroidal detachment is the middle layer of the posterior lining of the eye globe. It occurs when the fluid accumulated in the space, in the potential space located between the choroid and the sclera. And it may result from trauma, surgery for glaucoma, lens extraction for cataract, and in hypotony for any cause. The choroid detachment, usually it is posteriorly, not extend beyond the entrance of the vortex vein. This picture just to show the side of the foramina for the vortex vein is usually not extend beyond. So it will appear like convex shape bulging to the vitreous. To differentiate from retinal detachment, which usually firmly adherent to the optic disc. Another pathology which can be used or can get benefit from B-scan is intracranial, increased intracranial pressure. It can be used by measuring the optic nerve or optic nerve sheath diameter 3 mm beyond or posterior to the eye globe, 3 mm, and we measured here the optic nerve sheath. If it is beyond 5 mm, it regards abnormal. Some texts said we measure up to 6 measurements and we averaged it, and some only 2 measurements, the right and left, and measured both measurements. And the result of more than 5 mm, it means increased intracranial pressure. About intraocular foreign bodies, although CT is the modality of choice for intraocular foreign bodies, but we can get benefit from ultrasound. About types of intraocular foreign bodies can be toxic or inert, and about modes of damage could be due to mechanical effect, introduction of infection, or reaction of foreign bodies. And sure, it depends on the size, velocity, and type of foreign body. Usually, foreign body greater than 2 mm cause extensive damage, and lesions depend upon route of entry and the site to which foreign body has traveled. As anywhere foreign body on ultrasound appear as hyperechoic with acoustic shadowing or reverberation. And last topic, optic nerve drusen. This is not emergency, just not to mistaken with the foreign body or intracranial pressure. See, optic nerve is known as hyaline bodies. It's small collection of hyaline material within the head of the optic nerve. Most cases are asymptomatic, although patients may report episodic visual loss, usually found incidentally as echogenic focus within or in the surface of the optic nerve head. Thank you.
Question from the audience or some point to add or more to discuss?